Great, thanks everyone for joining in on our webinar this month called Recent Updates in Antimicrobial Stewardship Resources for Your Hospital. My name is Matthew Pitlick. I am the Medication Management Lead for the Iowa Healthcare Collaborative, and we're lucky to have this antimicrobial stewardship topic today. It's very relevant and very necessary for all of healthcare today, and excited for this webinar. As a reminder for a little housekeeping, please mute your phone lines as we perform the webinar. Do not place your phone on hold, as there may be some fun background music coming through. Handouts are available there. I see them coming through on the webinar chat, so if you see those, you can click on it and get the slides for today. Please utilize that chat box for questions as well. Be sure you change it to sending to all folks, all panelists and attendees. That way we can answer your questions. As a reminder, the session will be recorded as well, and materials will be posted to iCompass and emailed to all the registrants after this webinar. Today's speaker we're lucky to have is Dr. Amanda Bushman. Dr. Bushman received her Doctor of Pharmacy from Drake University and completed a PGY-1 pharmacy residency at the University of Iowa Hospitals and Clinics in Iowa City. She is duly board certified in both pharmacotherapy and board certified in infectious disease, which is a high accomplishment in the world of clinical pharmacy. Dr. Bushman joined Unity Point Health Des Moines in 2012, where she precepts students and residents on the infectious disease rotation and is an active member of the Iowa Pharmacy Association. Dr. Bushman's area of interest include antimicrobial stewardship, multi-drug resistant organisms, and antimicrobial dosing in obesity and advancements in microbiological technology. I'm lucky enough to call her a friend and colleague as well. When I have infectious disease questions, I call Amanda with those questions first, and she gives me answers rapidly and right away. So I will let Dr. Bushman take over from here.
Thank you, Matt. So today we're going to talk about some of the antimicrobial stewardship updates that came out in late 2019. The objectives for today are to apply the CDC core elements of hospital antimicrobial stewardship to our daily practice, to describe the impact of the 2019 Antimicrobial Resistance Threat Report, to identify opportunities available through the AHRQ Antimicrobial Stewardship Toolkit that's available. So looking at the CDC core elements in 2019, they first come out and say that stewardship programs can increase infection cure while decreasing the following: treatment failures, Clostridium difficile infections, or now it's known as Clostridioides, adverse effects, antibiotic resistance, hospital costs, and length of stay. And so I find this map graphic very interesting that is published by the CDC. And what this is this is from 2018, and it looks at the percentage of hospitals meeting all 7 core elements by state. And so at that time, 85% of acute care hospitals reported having all 7 core elements in place. And you can see that Iowa is at 79%, and so that is great, but there is still some work to be accomplished, and we will talk about stewardship programs. And I think a lot of us are doing stewardship activities in our everyday practice. We're maybe just not recognizing all the different pieces that could count as stewardship. So the document in 2019 is an update from the 2014 core elements document. And this addresses the following components of antimicrobial stewardship: hospital leadership commitment, accountability, pharmacy expertise, and I'm very excited about this one. This one was previously called drug expertise, but in this rendition is actually called pharmacy expertise. Action, tracking, reporting, and education. And so when we look at the hospital leadership commitment, this is defined as the dedication of necessary human, financial, and information technology resources. And this time they came out with categories labeled priority and other. And so we'll go over those categories and what that means from a hospital leadership commitment standpoint. So in the priority category, they are specifically calling out time for leaders to manage and conduct daily program operations. So again, it's really important to think about what your stewardship program looks like, and from a day-to-day perspective, what time that takes to run that program successfully. providing resources, including staffing to operate the program effectively. And so looking at what resources you have and what resources you're able to put towards stewardship to accomplish those goals. Meet regularly with program leaders to assess needed resources and goals. I can't stress enough the importance of this. I'm very fortunate where I practice, we do have a scheduled antimicrobial subcommittee that meets with pharmacists and providers and nursing leaders and pharmacy leadership, and that goes up to our P&T committee. But it's also the day-to-day looking at your resources and looking at your goals and looking at the projects that you want to work on. Also, I think the goal piece is super important for us, looking at what your goals are for 2020. You know, it's just early February, so setting those goals and then coming back to review them from time to time throughout the year. And again, at the early next year, looking at what you accomplished, what you're potentially still working on. Do you want to add some of those things to the next year's goals? I will tell you, in a recent accrediting body survey, I was specifically asked about the goals of our program. So it's important to have a good handle on your goals. Appointing a senior executive leader to serve as a program champion for the stewardship program, and then telling your program story, reporting stewardship activities to senior leadership on a regular basis. And I can't stress enough how important telling your story is. I call it beating my drum, and we'll talk about this throughout the presentation, but it's so important to be able to have your stories program, from goals to maybe it's a quarterly scorecard, and we'll talk a little bit about what is included potentially in a scorecard, to your antibiogram tells a story, to the projects that you're working on. All of those things are so important. First of all, it's important to get the word out and things that you're working on, but it's also super important to get the word out because there may be methods of collaboration in your hospital that somebody is working on something similar that you could definitely partner and collaborate on those opportunities as well. In the other category, there's integrate antibiotic stewardship activities into other quality improvement and patient safety efforts. Again, this is very important. I think about how many QI teams I'm on or asked to sit on for various opportunities and patient safety as well. A lot of times I partner with infection control and they have similar projects that may be going on or questions about different opportunities. It's important to set clear expectations for our leaders of the programs on their roles, responsibilities, and desired outcomes. Again, defining those roles and having people know what it is that they are asked to accomplish, and then having those outcomes, again, similar to goals in the forefront is always very important for success. Formal statements of leadership support for antimicrobial stewardship. Incorporation of antimicrobial stewardship activities into job descriptions and performance evaluations. Everyone can be a steward, everyone can be an amazing steward. And so I think we're all doing stewardship activities. We may just not recognize or classify them as such. And so again, you know, incorporating them kind of brings that to our forefront. Support training and education for program leaders and hospital staff. Again, that's very important to keep everyone up to date on the knowledge and information that's out there. Support the enrollment into the NHSN AUR module, including the information technology support. Support participation in local, state, and national antibiotic stewardship quality improvement collaboratives, and to ensure that time and support from other key departments and stakeholders is available. And we'll talk about this throughout, but stewardship is really a team sport, and you do really rely on other departments and stakeholders. So moving to accountability, in the accountability section, they talk about having a designated leader or co-leader. They also strongly mention dedicated time, and then as we talked about, clear roles and responsibilities. Again, having those meetings, whether they're scheduled or brief meetings, to again have check-ins on where everybody is in their project, so you're not duplicating tasks, but you're also staying on task. So pharmacy expertise, or previously known as drug expertise. So in the CDC core elements from 2019, they list dedicated infectious diseases pharmacists, which we know that that is not always possible due to resources and a variety of other situations. But more exciting to me is that we added the section of clinical pharmacists. Clinical pharmacists are a huge part of antimicrobial stewardship. And this is because they have integrated themselves into their teams, into their floors, and so there's a ton of opportunities for them to interact with those patient care teams and the bedside nurses and things of that nature. And so incorporating them is really a vital piece of stewardship. In fact, we kind of use a unique model in the fact that I have a core team of stewardship pharmacists that rotate through to provide coverage for me to have office time or project time, and it also allows them additional opportunities for learning and engaging in our stewardship program. And so actually one of our clinical pharmacists who supports the stewardship team is actually covering for me right now. So there's lots of opportunities that you can engage everyone. And remember, it's a team sport, so I truly believe everyone has a role. Also, there are additional training programs through the Society of Infectious Disease Pharmacists and also MAD-ID, which is Making a Difference in Infectious Diseases. These are both pharmacist-run organizations. And I've completed the one from MAD-ID, and I will say that it was a very good experience. They provided some didactic course learning and reading, and then what I found to be really interesting and helpful is you had to work on a stewardship project and submit that, and that was part of obtaining the certificate. And so really all those different pieces of that helped you then to take forward how to put together and do a formal stewardship project. And again, a lot of us are already doing these projects or have these projects on the table, so you're already working on them, but it's just another opportunity. So looking at the action piece, this should look very familiar to us because many of these things are found in the IDSA Antimicrobial Stewardship Guidelines. So they talk about prospective audit and feedback, and we should all think about this as the backbone or the meat and potatoes of stewardship. Again, looking at antimicrobial usage, looking at our patients, looking at our culture data, and providing real-time feedback is so important. Again, we're caring for that patient right in that moment, and that's the top of everything for us is patient care and patient safety. But again, having that conversation along the way and that dialogue is so important. Pre-authorization, again, is in the IDSA guidelines, and you can talk about, do you need to have pre-authorization for the usage of certain antimicrobials, and that may or may not work at your facility. Also, pre-authorization has a lower level in the guidelines, so to say, as far as the ranking of the effectiveness of these methods. Facility-specific, treatment guidelines, community-acquired pneumonia, urinary tract infection, and skin and soft tissue infection. These are great ones to start with. Again, if you're thinking, gee, I'm a little bit overwhelmed, or gee, there's so much going on, how am I going to tackle all of these things? These are 3 disease states that have guidelines available from the IDSA. Some of them, the CAP guidelines just came out in the fall of 2019. The skin and soft tissue infection guidelines have been out for a few years now. And then UTI, I believe, is currently in the process of being updated. But these are great opportunities to start, and you can work on projects related to these disease states and then get physician buy-in that way. And that could be through a variety of things, whether that is education or algorithms or pathways or order sets from that standpoint, and then providing that feedback. When we talk about action as well, besides what we talked about on the previous slide, There's additional infection-based interventions that you could use in the action section, and that is sepsis, and I know that that's a big metric as far as CMS goes, Staph aureus, C. difficile, culture-proven invasive infections, and outpatient antimicrobial therapy. Again, transitions of care and what that looks like for our patients is so important, both from a multidisciplinary team and then getting all of the pieces together to provide that education so there's good understanding and so that our patient safely transitions to that home or outpatient setting. Looking at provider-based interventions, so there's the timeout, the antibiotic timeout, and that is, again, reassessing the need for antibiotics. This is usually at the 48 to 72 hour mark, and that's because a lot of our cultures are coming back at that time with data. And so, again, taking that antibiotic timeout. What's also exciting is with newer microbiology technology, you may have data even before that 48 to 72 hours. And then this is listed under provider-based interventions, but again, it's probably one of my favorites as a pharmacist and something that I'm highly involved in is penicillin allergy, or I like to call it allergy assessment. So again, taking the time with our patients and asking those questions about the penicillin allergy. What was the reaction? When did it occur? Be an investigator, a detective, and find out how you can incorporate all of that into their, stay in the hospital. Is there an opportunity to go talk to that patient and find out those questions? Can you look previously in the patient chart and figure out what happened there? Can you go to, can you call their outpatient pharmacy and figure something out of that nature? Again, asking those good questions and doing that detective work is so important. Looking at the pharmacy-based interventions that they call out, and I would say, like I mentioned in the previous slide, although they don't specifically list penicillin allergy under pharmacy-based interventions, I totally believe it is and should be. It's something that's a huge part of our daily practice. But documentation of indications for antibiotics, I think that this is a very an important piece of the puzzle, again, for pharmacists. If we have the indication for our antibiotics, this helps, especially in a concise manner, this helps to potentially impact some of the other bullet points downstream, and we'll get there. Automatic changes from intravenous to oral antibiotic therapy, the good old IV to PO. I know many institutions are doing that already. Dose adjustments, so renal dosing, again, making sure that the dose is adjusted for either renal or hepatically. Dose optimization, so again, using some of those PK/PD principles. Is the antibiotic time dependent or is the antibiotic concentration dependent, and what does that look like? Duplicative therapy alerts. So again, if a patient is on, say, Unicin or Zocin or Meropenem and the provider goes and orders Flagyl, again, that's duplicative anaerobic coverage, and so do you need that? Probably not. Why did they order the Flagyl? Did they forget a piece of it? Things of that nature. So definitely focusing on those alerts and asking those good questions. Time-sensitive automatic stop orders. So again, that goes back to the timeout period. When do you require physicians to put in a stop date in their antibiotic orders? So that they don't go on forever, or how are you ensuring their review? And then detection and prevention of antibiotic-related drug-drug interactions. And I get quite a few of these questions, as well as our pharmacy staff, and we're a vital piece to this drug interactions. Again, so when we get those questions, I feel like it's a privilege to answer them. Looking still at action in microbiology-based interventions, I think it's important to think about selective reporting of antimicrobial susceptibility testing or cascading antimicrobial susceptibility results. I think that that's an important piece of this. And again, that is also mentioned in various articles and guidelines, including the IDSA Antimicrobial Stewardship Guidelines. And then also the CDC recommends in the action section of comments in the microbiology reports. And I always, think of the one of if your patient has a strep, where it says, it could say something of like penicillin is the drug of choice for strep or things of that nature. So are there something to guide, again, our teams in selecting the most narrow spectrum? Nursing-based interventions, so I think that this is an awesome opportunity, and most recently in the literature, they've talked about the bedside nurses' role in antimicrobial stewardship. There is a nurse from the East Coast, I believe her name is Rita Olins, who publishes a lot on nursing antimicrobial stewardship intervention. And then there's actually a pharmacist from California, David Ha, and he also publishes quite a bit on nursing intervention and his experience. And so really incorporating the bedside nurse and our nursing colleagues. The CDC talks about optimizing microbiology cultures. Again, how is the culture collected? When is the culture collected, and the timing to antibiotics, and in all of those pieces, just so that you know, and again, that you're focused on that from a stewardship team, so you can kind of see the time sequences and all of that. Nursing can definitely help the pharmacy colleagues in the intravenous to oral transitions. You know, our bedside nursing colleagues know how a patient is doing from a nausea and vomiting standpoint, or tolerating an oral diet, things of that nature. And also the bedside nurse has an amazing opportunity to help with the timeout procedure that I talked about. They are on the ground right there at the bedside, and they can ask the physician, hey, it's day 4 of Zosyn. What are you thinking, or what is the plan for that? And they're great, you know, a great resource. And so again, incorporating them into all aspects of stewardship is huge. So again, I really think that stewardship is a team sport, and it really does take teamwork. In fact, antimicrobial stewardship is usually known as ASP, or Antimicrobial Stewardship Programs. And so where I work, we actually call it AST, which stands for Antimicrobial Stewardship Team. And you really need all the players of the team. You need the providers, you need the pharmacists, you need the nurses, you need our colleagues in micro. Again, this goes back to, as I call it, beating the drum. Anybody and everybody should be a steward and should be excited about participating. So moving on to the tracking. So the tracking talks about the antibiotic use measures and the AU module. And then also it talks about the SAR, which is similar to a SIR for our infection prevention colleagues. And then they talk about the DOT, or the days of therapy. And in the US, the days of therapy has become the metric that is preferred versus the DDD, or the defined daily dose. And then they talk about outcome measures from a standpoint of C. diff infections, antibiotic resistance, and financial impact. And then they talk about process measures. And process measures are specific interventions that are calculated based on your processes that are being implemented. And I will say this, process measures are easier to track and collect versus outcome measures, but they're all important, and many times we should be picking some from each category, process measures and outcome measures. So we're going to move away a little bit from the CD3 core elements for the next couple of slides, because I think this is really important. And so when we talk about metrics, I want to say it was probably 2 to 3 years ago, maybe not that long, there was a paper published in CID that was on metrics, and what they did is they put together an expert panel to review and assess antimicrobial stewardship metrics in the acute care setting. And the panel included adult and pediatric physicians and pharmacists. And so again, it had a very diverse group. And experts represented practice settings, including the government, teaching facilities, county health facilities, and the industry. So again, it had a wide array of people participating, looking at antimicrobial stewardship metrics. And they reviewed 90 potential antimicrobial stewardship metrics, and these were reviewed on a 9-point scale that was based on the following criteria: improved antimicrobial prescribing, improved patient care, utility in targeting stewardship efforts, and feasibility in hospitals with the EMR. And the proposed metrics were reviewed based on clinical literature, which further underwent review by electronic surveys and by the panel and the follow-up discussions. So 6 metrics of, remember they started, I believe I said with 90, so 6 metrics obtained scores of greater than 6 in all criteria, which were deemed to be ready for immediate use and tracking. And 14 metrics obtained scores of greater than 6 in all criteria except feasibility. And so these were recommended for future study. And so the metrics that were ready for immediate use were categorized under unintended consequences, utilization, and process measures. And so you can see here that on the unintended consequences, 2 of them were related to Clostridium difficile, and then also to drug-resistant infections. Utilization, again, looked at your days of therapy. And then process measures looked at redundant therapy events. And then metrics for future study included readmission related to infectious diagnosis, adverse drug events and toxicity, days of therapy per days present, total duration of antibiotics per admission, total duration of antibiotics per antimicrobial admission, antimicrobial error, appropriateness of therapy per institutional guidelines, adherence to guidelines, appropriate cultures collected, excess drug use, de-escalation performed, timing of culture collected, time to appropriate therapy, proportion of patients who received initial antibiotic coverage for a targeted nosocomial pathogen who also had a positive culture for that pathogen. So as you can see, there are tons and tons of opportunities out there, and you can see how this expert panel on metrics stratified that. And so I think that's really important to tie in when you're talking about outcome measures and process measures from that standpoint. And that, I believe, was a paper in CID, or Clinical Infectious Diseases. And so getting back to the CDC core elements, in 2019, again, they have a category for reporting and education, provide regular updates on usage and resistance. And so I think that this is really important as antibiograms and scorecards. And so we'll talk a little bit about the antibiograms later, but I do want to talk about the scorecard briefly now. The scorecard is a great way in a concise manner to display a collaboration of your activities. And it can include things such as your days of therapy for your antibiotics. It can include things such as significant clinical interventions. It can include projects that you're working on. It could include presentations that you've been giving to different departments or things of that nature. So it's really good to incorporate all of what you're doing into a concise report and then take that to your P&T committee, which then distributes things to your medical executives. And so again, it's talking about beating your drum and providing that information. And then take advantage of the opportunities to share your stewardship story. You never know where this will lead. It's so important to share your story and to beat your drum and to tell the importance and what is going on in your institution. Be visible and available. I can't tell you how important this one is. I was just sharing with Matt earlier that I was invited to a presentation that was being given by one of the infectious disease physicians at my institution. And I was very excited and went to the presentation. And not only did I learn a lot, and that was great, but I was there, and there actually were quite a few questions that came up about antimicrobial dosing and antimicrobial alternatives and antibiogram. And so there was definitely a time to share some of my information, and I was also asked to put together some additional information for the group. And so I think, you know, had I not taken that opportunity to be visible and available at this lecture, I would have missed out on a great opportunity and collaboration. And I call it beating your own drum. Any invite you get, any meeting that you can go to, any person that wants to collaborate on a project, take that opportunity, learn about it, see what opportunities can grow from there and you can run with. And then the CDC core elements talks about giving your program a checkup. And there's a checklist at the end of the CDC core elements from 2019 that helps you to evaluate your successes and opportunities. And again, you can use that to think about things potentially for your scorecard or things potentially for your goals or things potentially for future projects. Just kind of keeping all of that in the back of your head. It all kind of intertwines very nicely. So now we're going to move ahead and talk about the CDC threat report. So an update from the 2013 report that was given. So this came out as the next iteration of this. And this report is divided into 4 sections: the threat of antibiotic resistance, challenges and opportunities in detection and treatment for antibiotic-resistant infections, the national action to combat antimicrobial resistance, and pathogen summaries. And so it includes 18 pathogens listed into the following categories: urgent threats, serious threats, and concerning threats. And it also talks about what we should stop doing as a country. As a country, we need to stop referring to the coming of a post-antibiotic era, stop playing the blame game, stop relying on only new antibiotics, and stop believing that antibiotic resistance is a problem over there. It is everyone's problem. Everyone should be a steward. Everyone should be excited. If you ask me, we have a great opportunity set before us. So the 2013 report underestimated the burden of antibiotic resistance threats. And the good news is though, the deaths are decreasing since the 2013, although the 2013 report, as I just said, underestimated the burden. However, due to prevention of infections, stopping spread of bacteria and fungi, improving antibiotic use in human and animals, and vaccination has really helped in that arena. And so here you can see the overall numbers of antibiotic resistant infections and then the deaths from those antibiotic resistant infections. And what I think is the most interesting to me actually in this, I mean, the numbers are very important, don't get me wrong, I'm just not going to read them off to you. But in this iteration of the CDC threat report, the C. diff is specifically broken out. And so we can see the impact of that and what that is doing to our patients. So my nerdiness in this CDC threat report that I loved is there's comprehensive tables of the pathogens in this report, including the metrics from 2013 versus 2019, and if the rank had increased or decreased, or what significant changes were. So I thought that that was just an awesome part. And then the report also mentions patient-centered stories regarding antimicrobial resistance and their impact. And I will tell you that this is super humbling to read these stories, and also it's an honor to work in this field because of trying to help those patients. At different conferences and educational opportunities, I've heard patients or their families speak about their personal story relating to antimicrobial resistant infections. And again, it's just very humbling to be there to listen to their story. So again, I think that this is a great addition to the report as well. So what does this mean for us here in the state of Iowa? Again, I think that the CDC threat report is a great report. It gives us lots of things to think about, but what does it mean for us in Iowa? Or what does it mean for our local practice site? So the Iowa Department of Public Health and the state does require CRE to be reported, and so that is one of those things that was renewed for the 2020 year. And then one of my favorite things, again, maybe this is the nerdy part of me, is the weekly Iowa Department of Public Health email. So they send a weekly epidemiology email. It comes out on Friday. Anybody can sign up for it. And so it provides hot topics related to ID and epidemiology, both at the state level, but also things that are going on across the country. And then also to knowing your antibiogram. What are you seeing at your institution? Again, it's really important to know what's going on in your institution and what you're seeing at your institution, because while the threat report is great, that might not be what is the threat report for your specific institution. So finding what that means for you with your antibiograms. So antibiograms, again, I find the process super fascinating. I do have a very strong interest in microbiology. And also, when I started this role almost 8 years ago, somebody said you will become best friends with your microbiology team. And I didn't know what that meant. But now, almost 8 years in, I know what that means. So again, it has to be a team sport, and we need all of our colleagues to help us champion these efforts. So looking at antibiograms, how often are your institution antibiograms created and updated? Do you follow the CLSI or the Clinical Laboratory Standard Institute rules and guidance for the antibiogram? Are key stakeholders involved in the antibiogram creation process? So again, we'll get into the rules of how an antibiogram should be created, but you have everyone at the table so when they're created. Do your providers and teams know about antibiogram data, where to find them, and how to use them? I find that this is an amazing opportunity, again, to get out there and be visible and be available and beat your drum every time you publish a new antibiogram. And you don't want to overwhelm everybody because you're going to have lots of data there, but maybe pick out a few things that you want to highlight to those folks. Also, knowing where they can find them on your internal internet is super important as well. And so keeping that in mind. And then what is your data telling you? Take a look at that data. Are there opportunities for projects? Are there opportunities for order set review? I always think about when you are building an order set, if you can look at your local antibiogram data when you're making those empiric antibiotic choices, it's so much more compelling and helpful. And then also you can use that as a segue into getting providers to use those order sets. So antibiograms, again, there's lots of rules for them, and we'll briefly go over them. But it's kind of interesting from the standpoint, because I know probably before I started doing this job, I did not appreciate it near as much as I do now. So you need to analyze and present a cumulative antibiogram report at least annually is what the guidelines say. Again, I would look at your isolate count to see what makes the most sense for you, but you should be hopefully doing it at least annually. Include only final verified test results. Only include species with testing data for greater than or equal to 30 isolates. Include only diagnostic isolates. Eliminate duplicatives by only including the first isolate of a species per patient per analysis period, irrespective of body site or susceptibility profile. That's a mouthful. Include only antimicrobial agents routinely tested and calculate the percentage susceptible from the results reported, and do not report supplemental agents that were selectively tested on resistant isolates only. Report only the percentage of isolates that are susceptible. Do not include intermediate isolates, except in a certain case. For Streptococcus pneumoniae and cefotaxime, ceftriaxone, and penicillin, list the percentage susceptible for both the meningitis and non-meningitis breakpoints. For the Virden's group, streptococci and penicillin, list both the percentage of intermediate and susceptible isolates. And then for Staph aureus, list the percentage of susceptible for all isolates and also MRSA. So moving on to the AHRQ toolkit. So this is for the acute care hospital, and the toolkit assists in developing and improving your antimicrobial stewardship program, creating a culture of safety around antibiotic prescribing in your hospital, learning and disseminated best practices for the diagnosis and treatment of common infectious disease syndromes. And then in the category of developing and improving your stewardship program, there's presentations that are available that talk about antimicrobial stewardship program development, so maybe you're just in those development stages, effective behavior changes around antimicrobial prescribing. This is another one that I think is pretty fascinating, and there's literature out there more and more that looks at antibiotic prescribing and behavior changes. Sustaining stewardship activities. Again, the role of the bedside nurse, we talked about some of that, and then collaborating with microbiology. And again, in the toolkit to improve your stewardship program, there's that implementation guide, there's a gap analysis tool, there's a team antibiotic review form, and an antibiotic timeout tool. So you can see that this kind of goes into your incorporating all of these things into your daily practice. Looking at a culture of safety around antibiotic prescribing, there's presentations regarding making the case that improving antibiotic use is a patient safety issue. It wholeheartedly is, 100%. So we need to be thinking about patient safety. Improving communication and teamwork around antibiotic decision-making. Identifying targets for improvement in antibiotic decision-making. Again, changes in decision-making and those behavioral decisions as well. And then again, there's tools for the use here, and there's the commitment poster, and I think that's really fascinating. There's different literature in the press about commitment posters and how those work, antibiotic timeout tools. There's also some opportunities for reviewing and identifying adverse events as an opportunity for safety as well. So learning the best practices for diagnosis and treatment of infectious syndromes. So this kind of goes back, remember we talked about in the core elements, how we talked about UTI, cellulitis, and community-acquired pneumonia. Well, the AHRQ toolkit actually expands upon that, and they have best practices again for the UTI and the community-acquired pneumonia and also the skin and soft tissue, but they also have HAP and VAP as well, and they also bring in diverticulitis and biliary tract infections, C. diff, sepsis, bacteremia, and then the approach to patients reporting a penicillin allergy. So I think this is super, super powerful. The 4 moments of antibiotic decision-making. Number 1, does my patient have an infection that requires antibiotics? Number 2, have I ordered appropriate cultures before starting antibiotics? What empiric therapy should I initiate? Number 3, can I stop antibiotics? Can I narrow therapy? Can I change from IV to oral? And the AHRQ specifically says that these questions should be asked every day for every patient who is on antibiotics, and I would agree. I run around a lot of the time using the phrase, what is the plan? What is the plan? What is the plan? So again, asking those questions. And then what is the duration of antibiotic therapy for my patient's diagnosis? So in conclusion, I think we're all doing stewardship. I think a lot of times we don't realize what we are doing as stewardship is really stewardship, because it's always been part of, especially in pharmacy, the pharmacist's job, whether it's renal dosing or dose optimization with PK/PD, or adverse events, or, you know, all of those things are stewardship, and we're doing them. So how is your team doing? Go through that CDC core elements, that checklist, and give yourself a checkup. Are there any new or different ideas out there? I'll tell you one thing that I routinely do, just is another method to learning about what other institutions are doing and what published literature is out there, is the ID world is big into Twitter and med Twitter. And so a lot of times you will actually see articles that are posted on Twitter, and then I will download them and then read them from there. And so that's maybe a quick 5-minute thing instead of going through, you know, just the index in a journal. Also, think about what your teams are already doing and share it. I can't tell you enough to tell your story. Share it. Share what you're doing. Share with other colleagues. Maybe they have a great idea that you could implement at your healthcare system. Maybe you're doing something that they could implement. Also, telling your story gets that administrative buy-in, and it really helps to spark additional conversations. And then brainstorm about projects and ideas that can be further developed. And keep the dialogue going and ask questions. And I can't stress that enough. I think really with, you know, if somebody comes to you with a question about stewardship, or you're in a meeting and there's a question or an opportunity, jot down those opportunities and circle back with those people. Keep that dialogue going. The more people you have on your stewardship team, the better it is for our patients and their safety and their outcomes. And so again, those are all wins for everyone. And again, we want the patient to be the ultimate winner in all of this. So I think that is all, and I believe I will turn it back to Matt at this time.
Well, great, and now we have time for questions. There's a few that came in along the way, and I'll kind of read them, and Dr. Bushman will answer them for you. So the first one we got was integration of infection prevention into the Quality Assurance Performance Improvement Committee is now emphasized as a requirement. What would be some measures you could identify that hospitals could use in their reports specific to their antimicrobial stewardship programs?
So I guess what I would do is definitely partner and work with your infection prevention team and kind of see like some hot buttons and some hot opportunities. Is there something that you could look at with maybe your C. diff rates? Is there something that you could look at with your surgical prophylaxis? Does the committee just want to hear about projects and ideas that you're working on from that standpoint? There's usually always an opportunity. Again, I think too, you know, you can tie in those things to like what antibiotics are on your surgical prophylaxis pre-op orders, and what's your antibiograms say about that? And are you noticing does infection prevention notice anything with your surgical site infections based on what those folks got, or what allergy was listed, or things of that nature? So there's always ways to tie in multiple projects. I'm very fortunate. My IP team is literally across the hall from me, and so there's a lot of running back and forth to share those opportunities.
Great. It looks like another couple questions came in, both related to the penicillin allergy work. Could you give a brief overview of that service, and what are you kind of looking for during the work? Are you identifying a true allergy or side effects and tolerances, or just a brief overview of that particular service?
Yeah, great. So what we do is our providers can send us an inpatient consult to pharmacy that says allergy assessment. And what we go through is we have a form that's an interview form. So we collect the data. So maybe I'm the patient and I'm Amanda Bushman, and I have a penicillin allergy listed, and it was rash when I was a child. And so then from there, that's the information that the pharmacist collected in the computer. So they'll go to me and they'll say, hey, can you tell us about this? Or what is your penicillin allergy? Things of that nature. And we have it very scripted. And then I may say, oh, maybe I know all the information. I had a penicillin allergy as a child. It was 1987, and it was a rash. Or maybe you get oh, it was a rash, but I don't remember when, or things of that nature. And then from there, based on what we find out, we also can go back in Epic and look to see what other prescriptions you've had. We'll call outpatient pharmacies, or if you use another provider, to see what they have in their records. If a penicillin is deemed to be the most appropriate drug for you, then we look at, depending on all the data we've collected, is the patient higher risk and would need higher risk but still meets criteria to undergo penicillin skin testing, or are they lower risk and they could potentially do an oral amoxicillin dose challenge? Or, you know, based on side chains and based on chemical structure, is there a way to use cephalosporins and then you wouldn't need that testing? Is there a way, if the patient needed more testing, could they follow up with an allergist in the community as well?
We had a couple questions come in asking if you might be able to share those forms with folks.
I can definitely go back and I can definitely ask if that would be okay.
Fantastic. There's a lot of resource sharing going on, which would be really, really helpful if we could. And then one more question came in: is the AHRQ toolkit available for open access? And yes, it is. I looked into that. It is available on the AHRQ website. Good. Another question came in. And keep them coming in, guys. How do you engage patients and their families in your antimicrobial stewardship teamwork?
Yeah, that's a great question. I think that that's something that we could definitely all be better at. I know from my standpoint, I probably am engaged the most in people who have follow-up potentially and I may not be directly with the patients or families. Please note, I field a lot of questions on like drug interactions and adverse drug events from the nurses in the clinics. And so that's probably how right now I have that role. Definitely in larger academic medical centers, I know that they actually have outpatient ID pharmacists who see their patients in the clinic. Occasionally I'll go on bedside rounds, but that's probably maybe once a quarter if I'm available, just based on timing and projects and all of that. But definitely a good area where we should be more involved.
Good. Any other questions? Otherwise, it looks like we've answered. Oh, here we go. What do you recommend when it comes to provider backlash on implementing new protocols? We're a rural hospital with a consultant pharmacist doing reviews every 1 to 2 days, but have considered implementing a requirement to have another provider verify dosing on big guns, quote unquote.
Again, I really think that this comes down to those personal relationships and connections and really getting face time with the providers. I think, you know, if you can get into their group meetings or their different section meetings to talk about what your stewardship program is and tell some of that story up front, ask them if there's things that they would like potentially to partner with you on. Example, I'm working on an update for a pneumonia order set right now that's due for a physician group. And I was actually, while I thought it was up for review in 2020, it was not on the forefront of my mind. And I was actually contacted by the head of that department to say, hey, it's time for the ID colleagues and my pharmacist and you to all get together to review this. And I was like, sounds great. We'll do a first draft of pharmacy and then go from there. So again, I think it's just being visible and available. And also, I think taking a step back and seeing it really from the provider perspective. I mean, nobody comes to work to want to prescribe big guns or to overjump or any of that. We all have the same goal of the patient and patient safety and patient care as our #1 top priority. And so asking the questions of why. How did we get there? Or help me understand. All of those things are super important.
Good. So we got one more question coming in. This one's about the days of therapy metric. One hospital has been collecting data for almost a year now. How do we utilize this data? And is there a benchmark in literature that we could strive to, or just how to best utilize it in our antimicrobial stewardship program?
So I think the thing is to keep collecting the data. It's really important because you have to look at your trends in data. So again, you not only need to look at, so this person has been collecting since April of 2019 is the overall trend, but you need to look at 2 specific quarters. So in the US, Usually your highest antimicrobial consumption is in Q1 and Q4, and that's because of the respiratory season in our country. Again, if you look at literature that was published from other countries, if they are from the Southern Hemisphere, that may be reversed. So again, just be cognizant of that when you're looking at the literature. But it's important to look too, you know, like look at your January to January. Also look at the whole thing from April of 2019 over time. But it's important to look from also a month to month and a perspective to perspective and what's going on out there. Like when you have influenza of a high rate, you're probably going to see potentially more antibiotic use from a secondary bacterial pneumonia. And again, there's ways to say if you need antibiotics or not need antibiotics, and that's a whole other lecture, if it's bacterial or just the flu. But from that standpoint, again, trending all that data and keeping track of it. As far as benchmark literature, so the big benchmark right now is submitting into the AUR, and then there you can compare yourself to hospitals of like size and makeup. So that is a little challenging at this point. I think once more people get reporting into the AUR, there will be more opportunities for comparison there. And then I saw somebody specifically ask about is penicillin skin testing offered at Methodist. It is offered at Unity Point Health Des Moines on the inpatient side, and we also do oral amoxicillin dose challenge if the patient is low risk. And again, that is just not giving somebody oral amoxicillin. There's a protocol in place and somebody with the patient for a defined time period. So again, there's lots of safety precautions in play.
Good deal. On the last piece that came in looked like a comment about you know, kind of developing the team and making sure the pharmacist is available at your critical access hospital, rural hospital, making sure that pharmacist can be there face to face, trying to develop that team mentality to work towards a good stewardship program.
And I would say, yeah, I would say I know it's hard with staffing and different opportunities and things that are going on. Again, too, I can sympathize with that because not that long ago, one day I was booked at 3 places all at once. And so, again, how you just make the best of the situation, and maybe you send a colleague who you've gone over documents with, or maybe you see if you can catch the next meeting, or if people read email. There's lots of different opportunities. Face-to-face, I think, is really great. If you can be in that face-to-face, I think too, just being available, whether that's by phone or electronically available, is huge.
That's fantastic. And then no other questions came in. We are right at our time. This was very informative, lots of information, lots of great questions. So thank you for participating and putting those questions in. And great session today. These materials will be available, handout and slides. The recording will be posted to iCompass in a few days. If you need to register for iCompass, you will find it at that particular website. iCompass did replace Innovation, kind of our old messaging and social media, internal social media type piece. So if you need help, you can contact your clinical quality consultant for assistance. And then all registered attendees will also receive the information in a follow-up email as well. So thank you very much again for the time, and contact us if you need anything in the near future.